I'm Gary Clifford. I'm the interim chair of biomedical informatics at Emory School of Medicine. I think it's a lot of things to a lot of different people. My own thinking is that, it's where biomedical engineering meets information theory. It's all about how do we push information around, and it can be anything from genetics through to mHealth. I mean, you can see where we're going. We're going to cloud infrastructures, distributed computing. The volume of digital data and the velocity of digital data is just increasing exponentially. And anybody not working in the digital domain is stuck firmly in the 1970s, 1980s. So if we're either going to go backwards or we're going to go forwards. And so I think we have to go forwards, don't we? It's the place we need to be investing. What excites me about it is people are generating these data, and they're generating them on an enormous scale in a very natural way. It's a natural instrument that we interact with, and it has all the qualities that we need in a device for capturing data. It has this suite of sensors, it has direct connection to the internet, it identifies the individual very specifically, which is one of our biggest problems in medicine, is knowing whose data belongs to who. And it has enormous computational power on it. I remember when we first started looking at using phones in medicine and thinking about its potential, and you could see where it was going, and you could be frustrated by the current systems, the very early smartphones, but you could see where the computational power is going. And now the phone in my pocket is about 5 or 6 times as powerful as the PC that I wrote my PhD thesis on. So I'm eternally excited about the idea of this distributed computing power that we have in our pockets, and the ability for it to push data into the cloud for us to continually track the behaviors and the health of an individual. Unlike a medical device that you put on an individual, a phone isn't FDA approved for medicine, so it's difficult to use it in any validated sense. And the reason for that is very important. The reason is that it's a heterogeneous collection of different platforms. It's not one device. When you have a medical device and you put it through FDA approval, they certify that this particular device running this piece of embedded software will produce the following results, and therefore it's safe under these conditions, and it should be used for the following types of medicine. Now we're talking about using these enormous heterogeneous hardware platforms running constantly evolving software and operating systems. And the idea that you could ever come up with a closed, predictable software system that the FDA would approve is a long, long way off. And so what you have is this idea that either you have to tailor it to an individual or you have to aggregate across large populations. At least that's where we are at the moment with mHealth. And so I suppose the goal at the end of the rainbow that we're chasing is, how do you provide quality healthcare information from this type of platform? I think there's 2 really good examples at the moment. There's 2 areas where I feel mHealth has great potential. One is low to middle income countries, where it's sort of a tabula rasa. We have no digital healthcare system, or very little. And it's often a highly distributed, non-centralized healthcare system. And so having the ability to mediate data personally is going to be an enormous leapfrog effect in healthcare, potentially. So we have a project down in Guatemala at the moment. I just came back yesterday, in fact. We're wrapping up an RCT down there, randomized control trial, looking at the potential to use a smartphone by illiterate lay midwives. So these are essentially women who move from village to village looking for, by word of mouth, for pregnant mothers and offering them help in the move through pregnancy to childbirth. And we've taken a group of 50 midwives, working with an NGO, of course. You have to work with a local partner who already delivers a standard of healthcare. And we've provided training for a smartphone with a low-cost $17 ultrasound device that plugs into the smartphone and a blood pressure cuff. And they screen the women monthly, and they're looking for preeclampsia, high blood pressure. They're looking for abnormalities in the heart rate variability that are indicative of intrauterine growth restriction. This is actually a machine learning algorithm that we've developed to identify IUGR, intrauterine growth restriction, and also to refer the patient on in the event that any emergencies occur. The app is built as a series of culturally appropriate pictograms. So we work with an anthropologist who just turns out to be my wife, who's helped us design the culturally appropriate interface for the largely Cachiquel speaking, this is an indigenous Mayan language, Cachiquel speaking group of midwives. And all of the support system, all the help files are spoken in Cachiquel, and all the data is recorded in Cachiquel. There's no written language actually for this, which makes IRB approval for it quite difficult, but it's a fun system to build because you're basically building a decision support system for an illiterate group. The intervention comparison, so the other arm of the intervention, is simply the same pictograms printed on a piece of card and then laminated so that it's waterproof. And then we train another group of midwives to use, or traditional birth attendants, to use that laminated cardboard as a decision support system. So we're directly testing, is a technology based on a smartphone that connects a decision support system straight through to a healthcare system more efficacious than a dumb phone or a feature phone with the number programmed into it and cardboard with the same decision support mechanism in there. I can't tell you the results of that because we are only just wrapping up the RCT at the moment, but the informal numbers show that there's been a significant impact on the population. And the question of whether you can take people with very little exposure to a smartphone system, although they do use quite complex phones themselves, and use that in a healthcare setting, there's strong indications that that's entirely possible and in fairly large numbers. So that's a pretty exciting one. We have an enormous potential there. We're connecting the phone directly through to an electronic medical record system, which is an open source system. The entire thing is built on open source technology, and the price point's extremely low for the entire system. So that's got me really excited. You know, the idea that we can transform healthcare by providing these enablers. But there's another layer to it that's really exciting, I think. When you take a smartphone system, you don't just have to give information to a user. You're capturing information from them at the same time. So these lay midwives have lots of local cultural knowledge about how receptive the mothers are going to be to certain treatments, and even down to the point of different colors mean different things in medicine. There are hot colors and cold colors. And some illnesses or medical conditions are hot and some are cold. And if you use the wrong color, then it no longer becomes trusted. So having the right cultural approach to something is very important. And we can capture this information back from the midwives at the same time because they can create logs of what does and doesn't work as they're moving through this process. So it's a continual system that we built with the midwives. We learned from them, we adapted it to their own cultural practices, and they became an inclusive part of the construction of this. And so I think that's where we're going with mHealth. It's not this didactic, patriarchal Western medicine where we just say, here's the drug, here's the app. Now give me your information back and I will give you the cure. I think it's going to become an organic system where we're feeding information back and we're learning from the user. It's also got the potential to create a distributed system that allows users to pass information between each other. So now you could have different midwives having social conversations through the phone and exchanging information about, I'm not saying we're doing this at the moment, but this is the next step, I think. They can interface with each other, exchange information, form a support network, and we can capture this information at the same time and work out what's working, what's not working, and even ask each other to diagnose problems when we don't have the bandwidth for the centralized doctor or nurse to provide the clinical information that they need. So I think there's an evolution to mHealth that's coming that is somewhere between distributed computing and crowdsourcing that is going to allow us to harness the local knowledge of individuals and the wisdom of the crowd, if you like. Sure, this is just as exciting to me, actually, and it's a homegrown project in that it's a US based project in Atlanta primarily, but we're expanding it through the Southeast. We last year we got funding from the NSF to realize a project that we've been hatching for a couple of years now. About 2 years ago, Dr. Herman Taylor, who's the head of the Cardiovascular Research Institute at mHealth School of Medicine, came to me and said that he wanted to expand and build an e-cohort of African American pre-CVD cardiovascular disease subjects. And he had run, previous to this, the Jackson Heart Study, which is the largest cardiovascular study of African American subjects anywhere in the world. And this had been ongoing for 20 or so years, looking at the evolution of cardiovascular disease. And one of the things that they had done as part of this was to bring people from the community in and train them in concepts around cardiovascular disease, and they became part of the study group that was studying the population as well. And this is, as you probably know, a difficult thing to do in disadvantaged communities in the United States. So, you know, the more disadvantaged you are, the more marginalized you are as a community, the more likely you are to have health issues. And in the United States, as in many places, these communities have often been unfairly experimented on. You know, we have the and that's a very moderate euphemism for what's gone on in the past. So if you look at things like Tuskegee and many other abhorrent things that have occurred in the past where the establishment has experimented on disadvantaged populations, you can see that there's an enormous distrust of these populations for people like myself or anybody who represents some figure of authority to come in and ask people to give up their data and become part of a study. So we had talked about how we would do this with eHealth and mHealth in a new population, primarily looking at younger African Americans in Atlanta. And we talked about how we could build an app ecosystem and an open source infrastructure that would not only be available to the communities that we are hoping to monitor, but we would actively involve them in learning how to program and how to become part of the project, to empower them to be able to produce code for themselves, which would increase their economic situation. They would also learn about healthcare at the same time, so they would improve their understanding of their own bodies and their own healthcare. And they would also be empowered to be a part of an open source community and an open source project and give back to their own communities. So the idea was to bring these communities in and make them part of this project. And we're just at the point now where we've realized we've got the funding for this, and we're working with the communities. We've been to multiple community coalitions to look at how we would sensitively recruit people into this. And this weekend, actually, we're running an ideathon where we're bringing in hundreds of local potential participants in this to work with us on ideating around the app. What do they want it to look like? We're actually collecting, and what do they want the app to do? We're collecting information on what geographic location, activity, sleep, movement, what restaurants they visit, what pollution they're being exposed to. There's no end of what you can pull from somebody's cell phone. But the question is, will somebody give us this information? And there's a cybersecurity issue really around this. How does somebody even trust you when, pretty much the question isn't, will I get hacked? It's, what will I do when I get hacked? That's the question nowadays around security. So how do you get somebody to trust them to allow you to use this kind of system? So we're building this with the communities. We're going to train them how to, and we already are training them how to code on this platform and become part of it, to understand the language that we're coding in and what information we're actually asking people to give us in order to do this kind of longitudinal study in cardiovascular disease. So this is something that's really exciting to me, that it's a new way of doing research. I think it takes participatory research right to its limit. We actually want people to take the platform, take ownership of it, build companies out of it, and change their health and economic status as a result of it. It's pretty ambitious, but I think we have a great team around it. I'm excited to see where we can take this.